Okay. Good morning, everybody. Thank you very much for attending this morning. We have Dr. Paul Matthew, who's from the Hematology Oncology Division of Tufts Medical Center and Associate Professor at Tufts University School of Medicine. We were just talking about his experience where he graduated from University of Lagos, the College of Medicine, Nigeria, and then migrated from his roots in India, migrated to Cook County Hospital in Chicago for his internal medicine residency, and then off to the Mayo Clinic for his HEMONC fellowship. He has extensive prostate cancer research and publications that have been posted. They've identified which I don't quite understand the mechanism, which he can probably elaborate upon, a seed and soil mechanism involving integrin cooperativity in tumor stromal interactions of prostate cancer, and has developed a proprietary biospecific antibody to target this biology. So we'll be very interested in seeing the depth and breadth of prostate cancer and hopefully prevent the lethality. But without further ado, Dr. Matthew, and I'll remind people in the chat box at the end of the conference will be a link for the program evaluation and for credit. And please post any questions you have in the chat box and we will answer them in due time. Okay, Dr. Matthew.
Well, thank you, Dr. Sidebottom. It's a pleasure to be acquainted and to meet the rest of you virtually. So this is this cartoon here represents I would say my passionate research interest in the laboratory, which is to say the unique tropism of disseminated prostate cancer cells to bone, which really accounts for most of its lethal behavior. This unique organ tropism that results in morbidity linked to mortality, bone pain, fracture, bone marrow failure, and so forth. But I'm not going to be talking much about my research just because I think it's a little esoteric for the group. Maybe I'll try and talk more in a more general sense that I hope will be more palatable and interesting, in a more applied sense that has practical value. And hopefully that's but I'm certainly happy to answer any questions on our research angle as well. So I think it's important to understand epidemiology. That's always a good place to start. And here with the arrows, you see prostate cancer retaining its top position by a long margin among invasive carcinomas in cancers in men in North America, comparable to that of breast cancer in women. And it is second on the list of cancer-related deaths, reflecting the variability in its lethality, similar to breast cancer in all women. But there are some very important trends I'd like to bring to your attention that have changed recently. Let's start in 1990 with the advent of the PSA test, which led to this huge spike in incidence, accounting for prevalent cases in the population, more so than perhaps new cases. And after things settled into a form of equilibrium, there was a fall. And then roughly around 2012, there may have been a drop in screening. And oddly enough, with the drop in screening, there has been what 2012 is significant for is the U.S. Preventive Services Task Force issued a Category D recommendation saying that the balance of risks and harms of screening for prostate cancer are unclear or undetermined and therefore cannot recommend screening. And I think that influenced some drop in screening across the country in variable regions. But oddly enough, now since that time, cancer cases have actually risen rather than dropped. There's been also a somewhat less impressive increase, but nevertheless an increase in breast cancer in women. And then a drop in mortality from prostate cancer. These are cancer deaths. And here's lung that has come down nicely with smoking cessation efforts and so forth. And in prostate cancer, it has been the advent of PSA screening that has been responsible through modeling studies for at least 40% of the reduction in the prostate cancer death during this time. And advances in care, no doubt, have also contributed to this as well. But you can see a plateau here. Can you see my pointer, by the way? Can everyone see my pointer? I'm using my mouse as a pointer. I just want to be sure.
Yes, we can see it. Yeah.
Okay, good. Okay, good. And so you can see this plateau here where that nice decline that was steady for a while seems to have stopped, consistent with that, or shall we say concordant with that increase in incidence that we have seemed to have noticed recently. And here's a stage-by-stage breakdown in a time slot of 2010 to 2015 that spans the US Preventive Services Task Force recommendation in 2012. So you see the drops in, this is localized disease A, this is metastatic disease B, and then this is low risk localized disease, and then this is high risk localized disease. These are the trends between 2010 and 2015. So you can see those nice drops in localized disease, and then it starts to plateau and maybe a slight uptick here. But look at the trends in metastatic disease, particularly in older men above 75, a rise in metastatic disease following 2012, and also a smaller rise in younger men, but a rise nevertheless. And a big drop in localized low-risk disease, but here is this increase in high-risk localized disease of late. So many have attributed these trends to these, so the increasing incidence is really accounted for by higher stage disease, both metastatic and localized high risk, and possibly because of a drop in PSA screening. And that's the concern. When looking at Black populations in the US in particular, this problem must also be scrutinized given their disparate impact amongst them in terms of the incidence and mortality from prostate cancer compared to other populations, Caucasians and Asians in descending order and Hispanics in descending order of importance. But look at the contrasting patterns of incidence and mortality here. You can see that similar spike in incidence, but look at what's happening with cell. It's not a plateau in cell death, it's an increase in prostate cancer deaths. It's not a plateau that you saw earlier with the general population, but a sharp increase. This particularly dramatizes the disproportionate impact of prostate cancer in Blacks, both in the US and across the globe, it should be said. Caribbean and Africa hotspots for this illness. So what are the screening, when it comes to prostate cancer screening, the underpinning, to all of these observations I've just made? There were two very large, just to remind you if you don't remember, there were two very large prostate cancer screening studies, one that was done in Europe among many nations, and another that was US-centric. Now we have very long-term follow-up, 16 and 17-year follow-up for these two large studies, which had, in fact, contrasting results. We had a significant reduction in the European study in prostate cancer mortality that has held up over time. The number of men required to be invited for screening has actually gone down. The number of men with screen-detected cancers to be treated in order to prevent one prostate cancer death has also gone down. So it's 1 per 18 now. I should say that 17 of them might represent overdiagnosis, whereas that one obviously benefited from the screen-detected diagnosis. Oddly, I should remind you that only Sweden and Netherlands, amongst all those countries that participated in this study, had the significant reduction in the risk of prostate cancer mortality. And more on that perhaps later. In the US, by contrast, the reduction was the methods that were used were slightly different, PSA and DRE, as opposed to PSA only in Europe. And here, this was a non-significant reduction in rate. And what is the argument was that the vast majority of men in the control group did get a PSA and it was therefore contaminated. So this has always been a source of sort of contention in the literature as to, does PSA screening actually help? But if you believe the European data, choose to believe them as a better study because of the lack of contamination, you will accept the potential role of screening in reducing prostate cancer mortality, which is consistent with a decline in mortality following the onset of screening since the 1990s. And then how can you deal with the problem of overdiagnosis, meaning you're finding cancers that would never threaten someone's well-being, and then they go on for treatment that perhaps they couldn't avoid treatment because of anxiety or other issues, and now they get an unwarranted complication of treatment such as erectile dysfunction or urinary incontinence, which is pure harm. So those are some serious questions. And so it's important, to to be able to discuss this with patients and express uncertainty about the benefit, but at least quantify it in some sense that they can understand. I think that's difficult to do for a primary care physician who's very busy. You want to screen men screening refers to men who are asymptomatic, and it should be restricted to men who have a life expectancy greater than 10 years. That's always hard to know how do you actually accurately do so in, say, a 70-year-old man or 68-year-old man with comorbidity. These are always difficult things. But it's been suggested that reducing screening to every 2 years, as was done in Sweden, the country that showed the particular benefit amongst all of the European countries, might be the way to go. So you're less likely to find incidents of low-risk cancers, perhaps by accident. PSA fluctuates a lot, particularly as you get older, for non-cancer-related reasons, including prostatitis. And then using this online risk calculator to individualize biopsy decision, I'll show you that in a second. It's something I make use of when talking to patients who are sent to me by primary care doctors who are aware I think about this problem, and the patient is keen to avoid a biopsy, and we're trying to make a decision, are we going to do a biopsy or not? And we've certainly started to use MRIs as well, and I'll talk about that. And then to use active surveillance for minimal risk disease, meaning patients, and I'll talk about what that is, and there are different guidelines as to how to go about it. But the point of the matter is that, you are not going to die of low risk disease. The chance of that is extremely low in the populations that have been studied so far. And I should make mention of the fact that African Americans or Blacks have not been studied as well. And it's not clear that this data is representative of their outcomes. It might be slightly worse. But overall, with active surveillance for minimal risk disease, the vast majority will not show a progression, and 44% avoid treatment outcomes. You may ask, well, if 80% show no progression, why don't 80% avoid treatment outcomes? Well, because once you get a diagnosis, there are other reasons why it triggers up intervention that includes anxiety, both from the doctor as well as the patient. So using PSA, you're a primary care doctor, you're seeing a patient in the outpatient for a well visit, and they have a PSA that's increased above 4, or it's increasing, and you're worried about it, as perhaps you should be. Here are the various tools that are being used to try and parse that risk in some sense to allow you to decide, does this patient need to see a urologist for a biopsy or not? Whether it's velocity, the free to total PSA ratio, age-specific ranges, it does go up as you age, or the 4K score, which has multiple parameters in it, including the free to total ratio, which will give you a sense of whether this patient ought to be evaluated. But as it turns out, now we are combining these PSA derivatives like the 4K score with multiparametric MRI, because that is now showing evidence of utility in picking patients who are at higher risk based on radiological abnormalities for clinically significant cancer. And suppose we chose to biopsy such a patient using multiparametric MRI fused with ultrasound, we can use tissue-based biomarkers such as these ones listed here. They can tell us what is you could say the molecular motor, the engine of this cancer. These tend to be cell cycle genes that tell us how fast these cancers tick over, and therefore they correlate with prostate cancer mortality or adverse pathology and so forth, and metastatic risk. And we can use that to say, okay, you have a low risk cancer, it's grade group 1, or grade group 2, and you have a very favorable MR and molecular phenotype, so therefore you should not get any treatment. We can just watch you. And here's what that myprostatecancerrisk.com utility looks like online. It's based on a large data set from the prostate cancer prevention study done a long time ago, studying finasteride as a chemoprevention agent. Anyway, using race, age, PSA value, the DRE finding, prior biopsy or not, and the percent free PSA, you can plug in, with these parameters, plug in what the chance of clinically significant cancer is, 9% for high grade, 18% low grade. 18% is probably something you don't want to diagnose. Then you have to decide whether that meets the threshold of concern to do a biopsy. So that's helpful. Notice that this does not include the MR. So we don't have a tool that integrates all of this with the MR quite yet. But things changed with this study from Lancet in 2017, where MRI can grade the abnormalities present on a scale of 1 to 5. It's called the PIRADS, P-I-RADS system. And you can see some of these scores in here in these boxes. Here's 3 to 5, which are the ones that are concerning in ascending orders of importance, 5 being the most concerning, 4 next, and 3 the least here. And 1 and 2 are generally considered very likely to be benign. And so here are these patients who are being studied systematically with MRI and saturation biopsies to see how MRI correlates with the presence of clinically significant cancer. And you can see that at MRI 5, let's take that, for example, over here. That's 109 out of 100. This is another 26 that didn't have cancer with the same abnormality. So let's add the two. 109 plus 26 is 135. So 109 out of 135 with MRI 5 had clinically significant cancer, right? Whereas, let me go to the other side of the spectrum, look at MRI 1, the PIRADS 1. So here's 1 out of 23, add the 22 on this side with no cancer. 1 out of 23 had clinically significant cancer. That gives you a sort of a scale by which you can tell that the PIRADS scale could help guide us toward identifying clinically significant cancer in patients. So this is generally speaking how we think about biopsy. And once we've made a diagnosis, the question is, what do we do with treatment? Well, there are 3 randomized studies that are informative in this regard, are the most informative in this regard, which I'll briefly review. There's the radical prostatectomy versus watchful waiting in a non-PSA detected cancer era, a very important study that continues to be important, done by the Scandinavians. And then in the PSA screen era, prostatectomy versus watchful waiting. And a similar study, but included radiation surgery or radiation versus active monitoring. So that was the PIVOT and the PROTECT. PIVOT was done in the US and PROTECT in the UK, Europe. So this is a Scandinavian study. This is men who were largely DRE detected cancers. And I think in a sense, it continues to my mind at least, even though DRE has never been shown in prospective studies because of the difficulties in uniformity of exam, variability in access to the prostate, and examiner-specific differences and so forth. It's just hard to standardize. But nevertheless, this represents cancers that were largely detected by DRE or symptoms. And here are the outcomes of surgery versus watchful waiting. And you could see that there was a statistically significant benefit from death from all causes that was largely in the men under 65, whereas above 65, you could not see that benefit. And the death from prostate cancer was similarly improved, not just overall. So there's concordance between prostate cancer specific death and overall survival. Again, in the under 65 group in particular, but also, as you will see, mostly in men with intermediate risk disease as opposed to low risk or high risk disease. And there was also a reduction in distant metastasis and the need for hormones. And here, the number needed to treat, meaning to have a surgery for one person to survive with prostate cancer was 8, which is considered a very favorable number. So this, you could say, is strong evidence for the benefit of surgery in localized disease. Take the PSA screen error, however, and the pivot, and here you see 790 men randomized to radical prostatectomy versus observation. You see much smaller benefits, which were non-significant overall. But if you looked at the men who had PSAs above 10, you could see on this forest plot a benefit suggesting some coherence with the previous study in that intermediate risk disease might benefit. But clearly, for low-risk disease, it was very hard to show any benefit, right? And although the trends were somewhat in favor of surgery, and we could argue you needed much longer term, this is 20-year follow-up, mind you, it's just hard to make that point. Understand, of course, that the rates of complications, naturally, incontinence, erectile dysfunction, were much higher in the surgical group. And here's the 10-year outcomes after monitoring surgery, radiotherapy for localized disease. Another very large study, 82,000 men were screened, received a PSA test, 2,600 received a diagnosis, and about 1,500 were randomized to either surgery, radiotherapy, active monitoring. And the outcome, you can see the prostate cancer specific exactly overlays each other at the end of a decade. And so regardless of the treatment assignment. But if you go on observation, then you can see there's a rate of metastasis that does emerge, but it's not lethal within this time span. So that's why the overall survival is similar. And so again, this is a screen detected population with very small tumors, low grade, low PSAs in general. Look at the low numbers of deaths at 10 years, very few. And again, that points to that, makes the point that I made earlier. So how do you talk to patients in the clinic? How do you think about benefits versus harms? This is a very difficult thing to talk about, I would say. You can say if you're screened, you have a 1.1% chance of averting dying from prostate cancer, 0.3 from avoiding metastatic prostate cancer. But contrast that with the risk of harm, which is a 1.5% chance of developing urinary incontinence and a 5% chance of sexual dysfunction. And if you went on to be diagnosed and treated, then of course those risks are also similarly, different between each other. Obviously, the sexual dysfunction risk is very high. Men who are treated for prostate cancer, urinary incontinence less so, particularly if you use things like pelvic floor physical therapy, which I'm a big believer in. Right, so there are harms with screening, obviously. There's false positives. This does vary with age. As you get older, it gets higher. Prostatitis is not uncommon at all. You can see it on MR, in fact. You can see it on biopsies. And it's not uncommon to see men whose PSAs rise to 12 and then fall to 5 or 3 later, And then the biopsy complications. And there's increased prevalence of antibiotic-resistant colonization, Cipro-resistant E. coli, and so forth. Bacteremia, in fact, and there's pain, there's hematospermia, hematuria, things like that. It's rare that somebody dies from it, but I just haven't heard of such a case, but I'm sure it might have happened. And so, treating somebody who for a cancer that never be a problem is diagnosis. And I said earlier, that's pure harm. And then, of course, if they get radiation, there's one type of, complication, there's bowel or bother, and in more than half sexual impotence, whereas in radiation, at 1 in 5 requires some diaper use, and more than 2 in 3 with sexual impotence. I think the surgeons would disagree with this number, but that's sort of the data we see is men using a diaper just in case, including that kind of thing. So you got enough of a worry that you might leak a little, that you wear 1 pad per week at the end of a year following surgery. So that number is, whereas men who have real problems, that's really real problems in the sense, I take that back, that's not the right word. Problems meaning multiple pads per day, requiring intervention from a urologist to control, that's less than 5% for sure. So this was the current position, hasn't changed since then, that the U.S. Preventive Service now concludes with moderate certainty that the overall benefits and harms are closely balanced. And how they arrived at that is, it's sort of hard to, it's a discussion that is worth having, I could say. And so each man's individual values and preferences would determine whether they feel, the overall balance. And some, those of you who deal with patients and discuss questions of this kind will know the difficulty of these conversations. And in the end, they might say, well, doc, what do you think? You tell me what you would like to do. And indeed, that's what happens, because, and this is a paper I wrote some years ago about the real world of primary care, spare a thought for embattled primary care practitioners in the US, from whom all things are expected. Not only must they fully attend to the concerns of those who are healthy but worried, but also those who are worried, and those who are sick, but also must fulfill a robust checklist of quality measure within an increasingly shrinking time slot. The bottom line is that is it really true that these shared decision-making processes are happening in the clinic? And surveys by Paul Hahn, my co-author from Maine, suggest that in fact they are not happening. Maybe 2/3 of men who have had a PSA do not recall having a discussion of it. And 90% of men who did not have a PSA do not recall having a discussion about not having the PSA. So that's the real world outcome. And I think doctors just probably decide to hell with it. We'll just check it or we're not going to check it, depending on what they're thinking about the value of the PSA screen is. And or if you check it, we'll see. If it's abnormal, we'll deal with it then, And the problem with once you find an elevated PSA, what one sees is that it puts into motion a series of events that are very hard to reverse or go the quicksand. And I think that's the problem, endless repeating tests, antibiotics, perhaps the biopsy, perhaps MRI, whether or not you're going to get active surveillance versus treatment, it's anxiety provoking. I don't need to go into all of that. But once having made the diagnosis, this is our staging schema. T1 for localized non-palpable disease. T1C is the old TURP method, transurethral resections. T2 means it's palpable and restricted to one lobe, T2A, T2B, more than half of one lobe, T2C on both sides. T3 is outside of the prostate. T4, locally invasive, nodes that are regional, in the end stage, and then M is metastatic disease, castration resistant, and visceral involvement. You don't need to know all of these things, but just the way oncologists risk stratify patients and lump them into groups. The bottom line of all cancers, and prostate cancer is no exception, is your treatment is either localized, your cancers are either localized, locally advanced, or metastatic. So here are two localized cancers, here's some locally advanced cancers, and here's metastatic disease, and then the treatment is accordingly tailored. And we've sort of keep shifting how we describe the prostate cancer under the microscope and score them. Now we pretty much resolve ourselves into 3, 4, 5 instead of 1, 2, 3, 4, 5. Now it's like 3, 4, 5 pattern, and we add the most dominant score under the microscope to the subdominant score, and we get a composite score. It's like 3 + 3 or 3 + 4, etc. And then we can use permutations of that to come up with grade groups of 1 to 5 and show how well that correlates with outcome. That's sort of replaced the old system, historical system. And these are just the patterns under the microscope, getting more and more dissimilar from what a normal gland would look like as the grade goes up. And here's a summary of primary treatment. Low risk is defined by PSA. This is the D'Amico criteria. It's a radiation therapist at the Brigham. Most people have adopted his system using PSA and Gleason and clinical stage, as I just described, to put people into low risk, intermediate, and high risk group. And here's a nice overview of a general principle of management for low risk disease. As I've shown from those seminal studies, active surveillance is preferred. Particularly very, very low risk disease where you have 1 or 2 cores only with Gleason 6. But in my book, anybody with Gleason 6, regardless of the number of cores, is a candidate for active surveillance, or grade group 1, as we call it. Intermediate risk, we can, as you've said, there's very strong evidence for benefit, particularly patients with so-called unfavorable intermediate risk. We further subdivide them based on the number of cores and whether it's grade group 2 or 3. Meaning Gleason 4 is dominant, that's grade group 3, and it's either surgery or radiation therapy for 6 months, surgery or radiation therapy with hormones for 6 months, and if it's high risk, it's surgery or radiation therapy with hormones for 2 to 3 years. So, these are the outcomes for low risk survival at 5 years, biochemical free for if you were to intervene, which we don't do anymore, is 95%. For intermediate risk, 85, and for high risk, 55. So it gives you a grade in terms of this is the potentially lethal, this is the lethal face of the illness, since to honor the title of my talk. It really comes from intermediate risk and high risk disease, and it's really expressed over a long period of time, generally speaking, from 1 to 2 decades following diagnosis, usually in the second decade. And so some management trends that you're probably aware of or should be aware of, that robotic laparoscopic prostatectomy has largely replaced open surgery in the US, with benefits from reduced hospital time, blood loss, pain, incision is small, but no categorical improvement in complications of surgery such as incontinence or sexual dysfunction, or with cancer-related outcomes, it should be noted from randomized studies. And hypofractionated radiation, meaning instead of giving radiation for 6 to 8 weeks, they're now giving it on shorter timeframes with larger doses, is now being increasingly employed across all risk categories based on studies demonstrating therapeutic equivalence, with perhaps only increase in short-term GI toxicity as part of the guidelines now. Hasn't been universally adopted, but I think it's changing practice. And for a long time now, there's been a decline in the use of seeds in prostate cancer for different reasons. And training being one of them. And this is just an example of one of those genomic markers that we use in addition to this staging that I referred to in special contexts, that we can do a molecular study, and there's several of them, Decipher, Polaris, Oncotep. I just picked this one because I use this one more frequently. I just find this easy to understand, but others are perfectly fine too. There's no one that's better than others as far as I know. And just gives you a sense of what it does. It tells you what a genomic risk of metastasis, prostate cancer mortality, and risk of adverse pathology. And suppose you have a patient who has, say, a ton of Gleason 6 cores on biopsy and a bit worried, there's a lot of cancer here. Should I really be observing this patient? Or you have a patient with intermediate risk on the favorable end, such as 3+4, and you want to consider active surveillance, but you're not sure how much of a concern that is. So you can use a genomic tool. Those are some examples of how we use them. I would say prospective randomized studies using these tools are still required for fuller validation, but that's forthcoming. The other thing that's changing management quite significantly in recent times is the use of PSMA PET scanning, which in high-risk prostate cancer appears to be more sensitive. You can see here in red the performance of the PSMA PET compared to conventional imaging, which is CT bone scan, seems to outperform it in sensitivity largely and equivalent in specificity, although there are certainly false positives with PSMA PET, and one should be very mindful of that. It's not truly prostate cancer specific because other cancers can pick it up too. So that's also coming in, changing practice gradually in this context. So about 20 to 40% of patients will have the disease recur after primary treatment. So there's always a concern: how do you reduce the risk of relapse? And adjuvant radiation is certainly something to consider, particularly if there are high-risk features like extraprostatic extension of the tumor and surgical pathology, or positive surgical margin, or seminal vesicles are involved, to name 3. And there have been multiple randomized studies looking at salvage, meaning you only do radiation if the PSA crosses a certain boundary, say 0.2 and higher, rather than intervening with radiation right after surgery and perhaps compounding complications such as erectile dysfunction. So the studies seem to show, at least at the 5-year event-free survival landmark, that salvage radiation therapy is not inferior to adjuvant radiation therapy. And so it has been argued that salvage radiation therapy should be the standard of care, the new standard of care in high-risk prostate cancer following surgery. Well, what about hormone therapy? And taking you back to medical school or your biology classes, the hormonal axis, and its control of prostate cancer has been, long the standard in prostate cancer, and it remains a persistent standard. And a big takeaway from this talk is how important it remains. And here's Charles Huggins, the Canadian urologist at the Ben May Institute at University of Chicago, who made the discovery of this relationship between androgens and prostatic acid phosphatase, a biomarker study that was done long before the word biomarker became popular, and indeed one of the first papers in cancer medicine that showed benefit for a cancer with a therapeutic, even before aminopterin for acute lymphoblastic leukemia by Sidney Farber. It was 1946 cancer research. Could say he beat him to that. Anyway, just as a side note, and I always like to say this, his grandson, Gordon Huggins, is a cardiologist attending at Tufts. And spent some time at his grandfather's lab. Anyway, so here's the LH-RH control of pituitary, release of LH. LH goes to interstitial cells of Leydig in the testis, generates testosterone, which is interconverted by 5-alpha reductase enzymes to dihydrotestosterone, which then binds to this androgen receptor, which is actually a transcription factor, meaning something that regulates genes. And that turns that on, and it does its business in turning on the activity, proliferation, survival, and other dimensions of prostate and prostate cancer behavior. So we find different ways to get in the way of all of that androgen signaling axis. We use agonists of LH-RH paradoxically. This is actually another Nobel Prize was won for this particular development. Of course, Charles Huggins got his in the 60s, early 60s. And LH-RH agonists are now on the market. Degarelix and given subcutaneously, and relugolix is now newly available oral equivalent. And that blocks the LH release, super stimulation by the agonist. So the LH goes up with the agonist and then falls down, whereas with the antagonist, it goes sharply down. Or surgical castration, we used to do that in the old days, not anymore. I'm old enough to say the old days when it comes to prostate cancer. 5-alpha reductase are not particularly useful. They were studied in prevention, but failed to show any impact on high-grade disease, just reduced low-risk disease, which is not meaningful. And then we have a lot of new drugs that interfere with either the synthesis of androgens in the adrenal, in the tumor itself, or block its binding of these androgens to androgen receptor with great affinity. And that has really transformed the care of prostate cancer. It's a very interesting fact that castration alone, whether medical or surgical, does not fully eliminate the androgen signaling. Indeed, it is ramped up and amplified as a compensatory measure. So that's one big takeaway. And I'll show you more examples of that. So if a patient comes in with a prostate cancer emergency to the ER with a cord compression or a urinary tract obstruction, or rarely DIC or base of skull syndrome, which are rare, rapid castration is very useful. And Degarelix provides that because that's the antagonist. You get castrate levels of testosterone within 48 hours, as opposed to Eligar or Lupron, I should say, which takes 2 to 3 weeks really. And you can see a faster decline in PSA. Relugolix, as I said, oral, is an interesting new drug. It's a prescription drug. Therefore, it's always harder because it's expensive compared to something that you inject. It's always harder to get prescription drugs covered and without terrible copays. But that it might have an interesting effect on reducing cardiovascular complications of hormone therapy compared to the agonist. I won't say too much about that. But here's the point I made about residual androgens in tissue in men who have been castrated. You can see that there's a significant amount of dihydrotestosterone and testosterone that persists despite that. And that's the point of how this thing goes on. The other thing that happens, I don't apologize for the complicated slide, but all this is saying is that all of those enzymes that make androgens, and we all studied the layers of the adrenal, for example, and all of the enzymes that go into androgen biosynthesis, well, they're all heavily turned on as soon as you castrate somebody, medically or otherwise, and they upregulate the synthesis just to compensate within the adrenal and within the tumor itself, interestingly. That's called intracrine synthesis. And so we've developed drugs to get in the way of this. Abiraterone is a potent inhibitor of 2 of these enzymes, and that was developed by the British Medical Council many years ago, probably in the late 60s. And it's extraordinary how drugs developed a long time ago somehow have a sort of resurrection, like Rip Van Winkle, I guess. And anyway, so here it is, the first study that showed the benefit over a decade ago of using, in a man who has castrate-resistant metastatic prostate cancer, using a drug of this kind and showing that, yep, you can prolong survival. And similarly, with a very potent antagonist of the androgen receptor, we hear with this development from UCLA of MDV-3100 by Charles Sawyers, who's a legend in the field, and Michael Young, showed that men who were castrate-resistant also responded to this very potent antagonist better than bicalutamide, which is the old first-generation anti-androgen. So now there's a whole host of drugs like MDV-3100 and enzalutamide that are now on the market, as I'll show you shortly, that have also shown benefit in terms of survival in the disease and advanced disease. And here's an overview of all the medical therapeutics that someone like myself in medical oncology is using alone or in combination with other therapies across the spectrum of localized, locally advanced and metastatic disease. So that's a broad range, but many of these are these highly potent, hormonal therapies. And I'll describe some of the non-hormonal therapies as well in my. The old one was chemotherapy, which, prostate cancer for a long time was thought to be chemotherapy doesn't work in this disease, but Ian Tannock was, and others had shown the impact on survival of docetaxel, a taxane. And to this day, 18 years later, nothing has improved on docetaxel alone. A whole host of combinations have been studied, and I've been part of several of those studies. None have improved over docetaxel alone. It's an enduring mystery as to why we failed to do that. There must be a very good biological reason for that. Cabazitaxel is another taxane that has the virtue of being resistant to the MDR resistance pathway, which shows failed. And then there's a special problem with bone metastasis. And I showed you this slide, this man with supersaturation. This is technetium-99 bone scan. You're all probably familiar with technetium-99. It's linked to a bisphosphonate, which allows it to home to the bone and show up in areas of bone remodeling. Why? Because the bisphosphonate binds to something called hydroxyapatite, a complex molecule. It's part of the mineralized matrix that osteoblasts lay down. Osteoblasts are like the fibroblasts of your bone. They respond to injury, inflammation, or tumors such as prostate, which excite it through paracrine mechanisms to proliferate and differentiate and produce all the matrix that now the bisphosphonate can bind to, together with the technetium-99, and show you this scan. And here's a patient whose kidneys are missing in outline, even though it's normally excreted. This is called a super scan, simply because so much of this is taken up in the skeleton that very little is left to outline the kidneys or the bladder, and that usually the volume of bone metastasis correlates with survival. So this is what we call the lethal phenotype of prostate cancer. The most common lethal phenotype of prostate cancer is high volume bone metastasis. So radium-223, which is in the periodic table aligned with calcium, has structural homology with it and allows it to bind to hydroxyapatite naturally. So this radioisotope homes to bone, and when injected monthly times 6 doses, reduces skeletal-related events, including pain and fracture, but also improves quality of life as well as overall survival. It's the first organ-directed, bone-directed therapy to show overall survival impact and establishes some kind of proof of principle for this whole notion that if you were able to decode the biological mechanisms of bone metastasis, you would likely advance the survival of men with prostate cancer. And that's, of course, the work that Dr. Sidebottom introduced is what we're doing in our lab at Tufts. What about supportive care? Well, denosumab is a antibody against a molecule called rank ligand that is important in the activation of osteoclasts, and an antibody against rank ligand will impair the activation of these osteoclasts and therefore potentially reduce skeletal-related events, since osteoclasts are implicated in the resorption of bone. And here's this comparison of denosumab, this monoclonal antibody, against bisphosphonate, specifically zoledronic acid, showing that it seems to be superior. And indeed, it's easy and convenient to use. Although our endocrinologists prefer using zoledronic acid for men who have osteopenia, which is a separate indication for bone resorptive therapy. And bone health is important. I always try to include this in my checklist in the clinic. I try to understand whether they have accompanying osteopenia. So I do bone density studies in men with prostate cancer on long-term hormone therapy, which includes men getting 2 years or 3 years of hormone therapy with localized disease getting radiation, or men who have metastatic disease who are on indefinite castration therapy. I consider giving them calcium, usually around 1,500 milligrams per day. I prefer giving calcium carbonate with meals because it has to be absorbed by the acid, and vitamin D 800 to 2,000 a day. If someone's taking a proton pump inhibitor, H2 blocker, you should switch to calcium citrate instead. And twice-a-day dosing is best. And then, of course, I use denosumab if they have bone metastasis, whereas if it's just osteopenia on bone density, then I'll use Prolia, which is a lower dose given every 6 months. I don't use zoledronic acid so much, although, as I said, the endocrinologists prefer the zoledronic acid, less rebound, as they say, when you stop the drug. So what about immunotherapy? Everybody loves immunotherapy. We've had a cancer-directed vaccine called Sipuleucel T. It's a bit of a relic now. This is an old study. This is a vaccine that was created using the patient's peripheral bone marrow mononuclear cells incubated with an antigen, prostatic acid phosphatase. And it did show some benefit compared to placebo. And, unfortunately, this drug is cumbersome to create. The vaccine is cumbersome to create, and the company went bankrupt for a while, and so the uptake has been very poor. Next generation sequence is a new sort of frontier in advanced disease. When I say new, it's not that new, really. Here's a study that I was involved with Foundation Medicine. In a large number of patients screened for, the patterns of mutations, and there've been other studies that have shown that. But just to make the point that, there are defects in the tumor genome that could be targets for therapy. And here's one example of homologous recombination. This refers to repair of double-strand DNA breaks. And there's a drug called polyadenylyl ribose polymerase 1 inhibitor, or PARP1 inhibitors, olaparib and rucaparib, are both FDA approved in prostate cancer. Why? Because when you use a PARP inhibitor, you impair the repair of single strand breaks in DNA, which occur naturally during DNA replication and other contexts. And what happens is that this results in double strand breaks eventually. And in tumors that are deficient in repair of the double-strand breaks, it undergoes cell death or apoptosis. And so if you give, and a classic example of this is someone with a germline BRCA1, BRCA1 or 2, and it's been long known that these drugs are effective in germline BRCA1 and 2 mutations in breast cancer, and certainly now in prostate cancer as well. And there are a lot of studies undergoing in combination, olaparib in combination, and the studies that have shown the benefit include olaparib versus a hormone therapy after they've had a prior hormone, showing a clear benefit for the use of olaparib in progression-free and overall survival in this context, particularly in men who have BRCA1, BRCA2, or or less likely ATM mutations. And there's controversy over ATM. And there's the other study, Triton, with rucaparib after docetaxel showed benefits specifically in the BRCA1, 2. So the point of the matter is that we do look for these mutations using next generation sequencing and tailor therapy in this personalized context accordingly. I made mention of the fact of germline mutations. About 12% of men with metastatic prostate cancer may carry a germline mutation. So we do send men to clinical genetics for screening for germline mutation if they have high-risk localized or metastatic disease. For high-risk localized disease, incidence may be 5%, and metastatic disease 12%. That's the published incidence. But I'm sorry to say that I haven't had such luck in identifying that incidence so far, but I do keep sending them there. Immunotherapy in general has a low activity, variable from 0 to 15% has been reported. Many of you who are oncologists will know the biology of how the T cell is activated. It's a co-stimulation event where the tumors, the antigen-presenting cell is presenting antigen, and there's a co-stimulation. And all the immune checkpoint inhibitors do is block that whole process of co-stimulation, either by engaging a molecule that shuts that process down called CTLA4, or PD-1 or PD-L1. I don't think we need to go into too much detail of that for the purpose of this talk, other than to say that these drugs are now standard of care in a variety of malignancies, including renal cell and urothelial carcinomas, the ones that I treat regularly, but have not found a place in prostate cancer on a standard basis. And why? Well, their tumors may be largely, from an immune context, divided into inflamed, immune excluded, or immune deserts, where there are no T cells at all versus they are infiltrated. And prostate cancer falls on the spectrum of immune desert, unfortunately. And there it is, a largely immune desert phenotype. There's some notable examples, exceptions to that. All that being said, pembrolizumab was approved across all tumors, as you may know, for microsatellite unstable or high mutation burden tumors. So if you do have a patient who has that on next generation sequencing, that is something to consider. And I did have a patient like that. This is a patient with a polymerase Eta mutation on next generation sequencing, a whole host of mutations. This is a high mutation burden tumor. He had an aggressive variant prostate cancer that was progressing despite hormone therapy and chemotherapy, obviously potentially lethal. But with the use of pembrolizumab, he went into a complete remission and he's now free of disease. So I think going on 7 years now. He made the cover of the Boston Globe, and Foundation Medicine is milking him for all it's worth for promoting the value of this test. But it's sad to say that this is a very rare finding. We do not find men with disease like this very often, and rare, and these immunotherapy complete remissions are truly rare. So I mentioned PSMA PET scans earlier, and this is certainly being approved for use in staging high-risk disease. We've been using it there. We're using it for evaluating men with PSA alone recurrences following surgery or radiation therapy, particularly following surgery, but also now for men who have castration-resistant disease who have failed frontline hormone therapy and chemotherapy. And so now we can tag this PSMA. I don't know if I mentioned PSMA stands for prostate cancer membrane antigen, which is expressed in the tumors of castration-resistant disease at least 75-80% of the time, and can show this extraordinary labeling of tumor and how it can regress with therapy when you connect it to a radioisotope. So basically, it's like a smart therapy connecting a radioisotope, which is cytotoxic, to an antigen. And here's the pivotal study of PSMA lutetium therapies called Pluvicto now, compared to standard care alone, showing this benefit in overall survival. A second study that compared it against cabazitaxel, the chemotherapy agent, did not show the overall survival benefit, but showed progression-free survival. So there's some mixed assessment of the role of Pluvicto, but certainly something that is becoming more and more standard. It's obviously it requires nuclear medicine imaging and therapeutics, and that has to be set up accordingly. So there's some special considerations. Men with oligometastatic disease, meaning one or two sites of disease restricted, usually the bone. If that's the only site of advanced disease, can you do something about it by, for example, delivering stereotactic ablative radiation therapy? And there's some studies of an earlier stage randomized phase 2 mostly that show the hint of benefit, particularly in reducing the next treatment, meaning sparing men from additional burden of therapy with a relatively mild and well-tolerated treatment. So that's more data is required to annotate that more. And so men who have low volume metastatic disease may benefit from radiating the prostate if the prostate has never been treated before. Obviously, there's an increasing rate of men presenting with metastatic disease, as I said earlier in my talk. But by treating the primary gland, you might improve outcomes. And here's the data from the Stampede study, which was done prospectively with a prospective hypothesis that with low risk burden disease, meaning less than 4 bone metastases and no visceral disease, you can get a better outcome. And indeed, that was confirmed and may be regarded as a new standard of care in men with metastatic disease. So that sort of rounds up all of the therapeutic agents that I was referring to in the talk so far. And obviously, I haven't talked about all the combinations and permutations and combinations of novel agents that are in clinical trials. Beyond the scope of this talk for this audience, there's a special problem of neuroendocrine and small cell differentiation, which represents another lethal entity in prostate cancer, very challenging, requires platinum-based therapy for control, which tends to be transient. And we need to learn more about the biology, which refers to usually the loss of the androgen receptor and significant amount of epigenetic reprogramming, resulting in these very challenging biologies with a different clinical presentation. So, as a summary, I think these next generation hormone therapeutics, exemplified by abiraterone and enzalutamide, the first ones I told you about, these continue to evolve, and find application in earlier disease states to optimize frontline therapy of prostate cancer, improve the control in the earlier high-risk localized setting in particular. And these advances in imaging and tumor genomic studies are also changing management and improving survival outcomes. And I think these two particular problems, bone metastasis and lineage plasticity, I illustrated, are two of the frontiers in biology in prostate cancer that I'm particularly engaged in my laboratory and represent major challenges toward therapeutic advances in this disease. And that's, I think, a nicely written overview of the disease in a recent publication in The Lancet. So with that, I'll stop, and I'm happy to take questions.
Thank you very much. It certainly is concerning in terms of the more severe end of the spectrum, a difficult to treat disease. I remind people that please click on the link in the chat box for to complete the program evaluation and receive credit. One question was, how do you know who will respond to Pembro?
Yeah, I mentioned the next generation sequencing can identify men with mismatch repair or a deficiency or homologous repair deficiency, referring to DNA repair mechanisms that are faulty, which may result in accumulation of mutations that increase the antigenicity of the tumor. But that is very rare, truly rare. And as I said, I had that patient who had that extraordinary response. I do it anyway, but I don't really expect to see patients like that on a regular basis. The question is, if they don't have any of those mutational signatures, will they respond to pembrolizumab? And so that is certainly possible, but the quality of the response is not likely to be very good. You're not likely to get a durable or a deep response. There is data on combinations that are maybe rescripting that perspective. In particular, for example, cabozantinib, which is a multi-tyrosine kinase inhibitor, has been combined with atezolizumab, which is a PD-L1 antibody, one of the checkpoint inhibitors. And that showed about 30% response in men with advanced castration-resistant disease, which is better than you would expect with either drug alone. So pointing to the fact that you can possibly overcome resistance to hormone therapy by modifying the tumor or the tumor microenvironment. So there's a lot of interest in that right now in different ways. How do you overcome the tumor microenvironment to enable the efficacy of immunotherapy? And there are other strategies like, for example, BiTEs, which are bispecific tumor T-cell engagers. You drag a T-cell to a PSMA, for example. The antibody has two antigen recognition sites, one for a T-cell and one for a PSMA. So you bring them in proximity and you're getting responses, uncontrolled observations, and those studies are ongoing.
I guess the challenge is whether or not, do you do those genetic studies on everybody up front or wait for a person's poor response to, first or second line therapies?
Generally speaking, that's what we do. Because some people, firstly, we don't do it in men with localized disease generally. It's usually in men with metastatic disease, particularly those who made the transition to castration resistant. That's when the value of that has become established, for example, and so you don't want to do it like 5 years before you really need it, because then the question is it the same genomic profile? Mm-hmm. Try to use it with contemporaneous tissue as much as that's feasible.
Sure. Sort of like doing, the culture and sensitivity at different points in time once you develop some resistance. So
that's right.
The duration of therapy with the PARP inhibitors or immune therapy, is it, once you sustain a response, or is there an ongoing management, chronic management?
Yeah, I think so. I think if you do get the management, you're not going to get a high quality response, meaning one durable and complete with a PARP inhibitor. You're going to get a partial response. And it may be prolonged particularly if it's BRCA1 or 2. You want to keep the patient on treatment. You may need to dose reduce for anemia and so forth, but you definitely want to keep the patient on treatment. And as I said, if the patient is on immunotherapy for some reason, I wanted to emphasize that it's certainly the vast majority of patients do not respond. I generally keep them on treatment as long as there's no complication.
Is there a higher rate of bone events in patients that are on hormonal therapy? Is there adverse effects?
Yeah, I mean, certainly the hormones definitely, cause bone catabolism. It's almost as soon as you start hormone therapy or castration therapy, you can see the metabolic machinery rewired and the osteoclasts start to kick in. So I think bone resorption is definitely a concern, aggravating the effects of age and immobility and other, comorbidities, which is why I pay particular attention to skeletal health, doing bone densitometry on all my patients and giving them calcium and vitamin D supplements and monitoring the bone density over time.
Is there a problem using the anti-androgen therapy in early disease versus waiting for metastatic disease?
No, we certainly use it in early disease context. By early disease, you want to be clear what you mean. I've used it, for example, in patients getting radiation therapy in lieu of castration therapy, just because I'm worried about the metabolic effects of castration therapy. I can use an anti-androgen that preserves androgen levels, has less impact on muscle and bone, and may not be inferior to castration therapy. His major issue is that of breast toxicity. So anyway, the questioner asked anti-androgens, by which I offer the literal interpretation, which means an oral medication that competes with the androgen binding. But if they meant hormone therapy in general, yeah, we do use hormones in combination with radiation, particularly in localized disease. When the PSA is just rising by itself and there's no evidence of disease on imaging, for example, generally speaking, unless the PSA doubling time is very rapid, we may not use hormone therapy. We may just watch the patient with a slow rise in PSA without intervention.
And the risk of prostatism and liver cancer development?
I'm not sure I understand the question.
Yeah, I don't. Yeah.
Yeah, I mean, with regard to someone who presents with metastatic disease and is on therapy, sometimes the prostate may be obstructed because of the cancer. You may need to do a strategic TURP. And very occasionally in patients with metastatic disease, the only site of progression at the time of castration resistance is the prostate. And one must always be aware of that. So I do DREs periodically. I always screen urinary obstructive symptoms in patients with metastatic disease with an intact prostate. And very occasionally that becomes a site of neuroendocrine or small cell escape, the one that I described towards the end of my talk.
Good. Well, I see no more questions, and time is nigh in terms of 9 o'clock. So thank you very much for elaborating us on the advanced therapies in these difficult to treat patients and the spectrum of screening that's necessary. So thank you very much, and we'll look forward to an update soon.
My pleasure.
All right. Thank you.